Hi everyone. In this video, we are going to do a rapid review of the CNS and psychiatry CCS cases, diagnostic workup along with the management. Once you master this diagnostic workup for the CNS and the psych cases, you will be able to score more than 90% on all of the CNS and psych CCS cases. So let's begin. CNS. The differential diagnosis for altered mental status includes, so we can divide this differential diagnosis into CNS causes, infection or trauma causes, or toxicity causes. So first of all, the CNS causes. What's the first thing that comes to your mind when you think of altered mental status? So it can be due to seizures or it can be due to meningitis. Next up, we have infection. So the infection can be a UTI, a pneumonia, or a sepsis. Then the trauma, we just have a trauma and head injury. And then in the metabolic causes, we have like electrolyte abnormalities, drug or alcohol toxicity, and then metabolic disorders such as hypoglycemia, thyrotoxicosis, uremia, and liver failure. So a quick review: whenever you think about altered mental status, divide the causes into 4 parts: CNS, infection, trauma, and metabolic or general throughout the body. CNS will include meningitis and seizures. Infections will include UTI, pneumonia, and sepsis. Trauma is just trauma. And then in the metabolic, it can either be due to some electrolyte abnormality or drug or alcohol toxicity, or some metabolic abnormalities such as liver failure, renal failure, thyrotoxicosis, or hypoglycemia. Next up, we have bacterial meningitis. So the goals of diagnosis for bacterial meningitis would first of all be that we have to confirm the diagnosis, and we confirm the diagnosis of course by taking the CSF out in the form of lumbar puncture. But before we do the lumbar puncture, we are concerned that if we do the lumbar puncture, it's possible that if the intracranial pressure is high, therefore it might cause brain herniation and death of the patient. Therefore, we always do CT scan without contrast before doing a lumbar puncture, just to ensure that there is no increased intracranial pressure and ventriculomegaly. Okay, so in the diagnostic workup, number 1, confirm the diagnosis with CT scan without contrast followed by the lumbar puncture. Next off, since we have taken out the CSF, now we have to do CSF studies in order to establish the cause. So what are the main things that you have to study the CSF for? So I have divided these CSF studies into 4 main groups, and the 4 main groups include: number 1 is the cell count along with the meningococcal antibody, right? Number 2 would be the protein and the glucose, and number 3 would be the stain and the culture sensitivity. And what cultures are you going to send? Viral, fungal, and bacterial culture. And number 4 are the special or the specific tests for certain specific viruses such as PCR for herpes and West Nile virus antibody. Then you want to make sure that you are going to fast forward and see the findings of the CCF exam. If you have viral meningitis, you are not going to give antibiotics and just give supportive treatment. So this was number 1, which was confirm the diagnosis with CT scan without contrast and lumbar puncture. Number 2, establish the cause with the CSF findings. And number 4 is to do a CSF workup, since the patient also has to do a fever workup, since the patient also has fever, with sending the blood, urine, sputum, and stool culture sensitivity along with the chest x-ray as needed. So 3 main goals for meningitis include confirming the diagnosis with CT scan without contrast followed by lumbar puncture, establish the cause with the CSF studies, which include CSF cell count along with the meningococcal antibodies. Then we have the protein and glucose, stain, CSF stain and culture sensitivity, which includes viral, bacterial, and fungal culture, and then specific tests such as PCR herpes, and then West Nile virus antibody. Next up, we have the fever workup with blood, urine, sputum, and stool along with the chest x-ray. And in the treatment, our 2 main goals are: we are going to control the infection along with control the inflammation. So infection is with, if it is bacterial meningitis, we are going to treat it with ceftriaxone and vanco, and if it is an infant or elderly patient, we are going to add ampicillin for more coverage of listeria. And then if the patient has a sort of fungal, we find out that it's a fungal meningitis, then we can of course give treatment accordingly and give amphotericin B. And if it is tuberculous meningitis, then of course the right protocol. And for the control of inflammation, we have dexamethasone. And if we find out that it's bacterial and Neisseria meningitis, then we are going to give rifampin to the close contacts. Okay, TIA. For the diagnosis of TIA, our main goals are to establish the diagnosis and rule out that if there is some bleeding or ischemia actually happen, for which we are going to do a CT of the head and MRI of the head. CT will help us rule out the bleed, so it's without contrast, and MRI will help us to rule out the ischemia. Then we are going to establish the cause. What was the thing that caused this TIA? So there are four main things that you have to keep in your mind. Either it was some sort of carotid atheroma which actually got lodged off, it went into the brain as an embolus and caused this TIA, or there was some bleeding, BT, APTT, INR, bleeding derangement, bleeding disorder that caused this TIA, or it was like some inflammatory pathology for which you are going to do ESR, or it can be some sort of toxin, so you are going to do a urine toxicology. So number one was to establish the cause or rule out a bleeding or ischemia with CT and MRI of the head. Number two is that we establish the cause with either a begin with the carotid duplex, then PT, APTT, INR, ESR, and urine toxicology. And of course, it's a neurology case, so we are going to consult neurology as well as consult vascular surgery, since some sort of vascular issue, ischemia, bleeding might be involved, or carotid duplex might show carotid atherosclerosis. Then the specific treatment. If the patient has some sort of ischemia, then we are going to give him aspirin, and if the patient has high blood pressure, we will control it with labetalol or hydrolysine, and it's possible that it is causing intracranial bleed. So if there is a bleed, we can also give fresh frozen plasma, and the prevention for it would be, if the patient is diabetic, give a diabetic diet, and also you can give metformin, or if the patient is hyperlipidemic, you can give a statin. Next up, we have seizures. So the goal of diagnosis for seizures will be, of course, again, to establish whether it was a true seizure, right? And then we are going to find out the specific cause. So for that, we're going to do some CNS tests such as CT of the head along with EEG. And for finding out the cause, we can do a serum ethanol along with a urine or blood toxicology screen, just to find out if there is some sort of drug that is causing these seizures. And the specific treatment, it would just be like airway, breathing, circulation. Of course, first of all, general would be the general management, and then the specific management would be to give lorazepam if the patient is actively seizing at this moment. And if this is a first episode and the EEG comes out to be normal, then we are not going to give long-term antiepileptics. Yes, we can give lorazepam for the immediate control of this seizure, but if the patient does not have abnormal EEG activity, then it means that he does not have a seizure disorder. So we are just going to do symptomatic management and no long-term treatment. Then of course, in the prevention, we are going to advise that the patient do not drive, because of course it's dangerous for the patient. Next up, we have GBS. So for GBS, we have four main goals for establishing our diagnosis. The four main goals include, first of all, we are going to confirm diagnosis with a specific test that would be EMG, that will tell us that, of course, there is some sort of peripheral neurological deficit. Then we are going to hunt out the cause, whether it is a pulmonary cause, a neurological cause, or a general cause, right? So for pulmonary, of course, what's the thing that you can do? You are going to also establish the respiratory status as well, right? Or there is some pulmonary infection. So that would be the chest x-ray and the pulmonary function test. Then you want to establish some neurological issue, and that would be with MRI of the spine and lumbar puncture with CSF analysis, again, to rule out some sort of meningitis, right? Okay, next off, we have the ruling out of the other causes, and that I have memorized with the mnemonic VIT. VIT is for vitamin, VIT. So V for finding out some vitamin cause such as vitamin B12 or folic acid that is causing this peripheral neurological deficit. I is for some infectious disease cause such as HIV or VDRL, and T would be for some sort of toxicology such as heavy metal screen. So that concludes our GBS diagnostic workup. So we are going to first establish the cause with EMG. Next off, find out the specific cause with pulm, neuro, or rule out other causes. Pulm will include chest x-ray and pulmonary function test. Neurology would include MRI of the spine, lumbar puncture with CSF analysis. And then we are going to rule out the general other causes with the VIT, which includes vitamin B12 and folic acid levels. Infection would include HIV and VDRL screen. and D for toxicology would include heavy metal screen. Then we are going to do, of course, the general supportive measures if the patient can't breathe, the airway, breathing, and the circulation, along with incentive spirometry in order to improve his breathing. Next off, we have the specific disease control. If it is established, then in fact it is GBS. We are going to give him IVIG and of course consult neurology since it's a neurological case. Next off, we have subarachnoid hemorrhage. So the goals of diagnosis are again to establish that it is really a bleed, and after that to establish the location of the bleed if you want to, of course, like fix that bleed and close that bleed, right? So for establishing the bleed, do a CT scan of the head without contrast. Of course, if you put in the contrast, you will not be able to see the bleed, right? So CT scan without contrast, followed by establishing the location with angiography of the cerebral arteries to identify the cause or the source of the bleed. Next off, the treatment, we are going to divide it, of course, the general supportive measures, airway, breathing, circulation, of course, exists. And then specifically, we are going to do some medical management and some surgical management. So for medical management, we can do blood pressure control, and specific calcium channel blocker that is used for subarachnoid hemorrhage would be nimodipine. And then for the surgical management, of course, we have to consult neurosurgery for clipping the bleeding source, and of course the pre-surgical orders, which include NICE PT, which is NPO, informed consent, cefazolin, E for EKG, and then PTA PTT along with the blood type and cross match. Next off, we have normal pressure hydrocephalus. Now the goals of diagnosis are, of course, like to confirm the cause with ventriculomegaly, that would be MRI of the head, and again to rule out other causes, other general causes with the mnemonic VIT. So V is for vitamin B12 and B1 levels, the I is for some sort of infection such as VDRL, and the T over here is not for toxicology, rather it is for TSH. And the treatment, of course, since it is like increased accumulation of the CSF that is causing ventriculomegaly and these pressure effects, we are going to do a lumbar puncture in order to relieve the high CSF pressure, and after that it's a neurological case, so we are going to consult neurology. Psychiatry, panic attack. So of course, panic attack is going to managed in the be managed in the ED, and for the diagnosis, of course, you are going to rule out the other causes because it is a diagnosis of exclusion. So rule out any deadly CVS or pulmonary causes. That would include doing an EKG, a troponin, and a chest X-ray if the patient has some sort of breathing complaints. Next off, we have the treatment. Of course, the general supportive treatment includes airway, breathing, circulation, and then the specific management would be to calm down the patient. The acute management would be lorazepam, and then the long-term management, which you are going to start giving in the ER so it can continue and prevent the recurrent panic attacks, that would be sertraline. And of course, it's a psychiatric case, so consult psychiatry and also consult psychology just to establish that it is not like it is an isolated panic attack or it is a repeated panic disorder. And for the supportive, teach the patient relaxation technique so that this panic attack can be avoided in the future. Next off, we have depression. For depression, we are going to do all the basic stuff. Of course, again, just like panic attack diagnosis, depression is also a diagnosis of exclusion. So remember our C5 UB and G3 MPL, which was MPL was with the maple mnemonic, right? So C5, which includes CBC, CRP, and then the chest X-ray and complete metabolic profile, and as a complete metabolic profile and creatinine phosphokinase. And then for U, we had urine analysis, urine culture sensitivity. For B, we had beta HCG along with our HbA1c. E, we have ESR, EKG, echo. T, we have toxicology, TSH along with TROP. For M, we have magnesium. For P, we have phosphate and PTA PTT. And then for L, we had LDH, lactate, and lipid profile. So just to all the basic tests, just to establish that there is no other pathophysiology that's going on. And then for the specific treatment, of course, it's a psychiatric case, you're going to consult psychiatry, and for the specific treatment, you're going to start some sort of antidepressant such as citalopram along with psychotherapy. And if the patient is suicidal, advise some sort of safety plan or suicide contract. And for the better stress management, of course, advise exercise or relaxation techniques. Next off, we have drug toxicity. So in the drug toxicity, it can either be like general drug toxicity in which which there is like you have to hunt the cause, then of course you're going to do screening for all the drugs. But if you find that it is specifically alcohol withdrawal and the patient is having seizures, then what you can do is that a CT scan of the head to rule out some sort of brain injury, and the specific treatment would of course be focused on what is a patient with alcohol abuse actually deficient in, right? So that would be the general supportive measures with vitamin B1, 6, normal saline, and folic acid. And for the specific treatment for the control of seizures in the ER, we are going to give lorazepam, and then of course psychiatry consult and substance abuse consult. And in the prevention, consult social services. The patient might be homeless or have some other issues at home, and then naltrexone for additional control in order to prevent the patient relapsing into alcohol abuse again. Now, this is the case in which we have general drug overdose, right? So one is that you just order general blood and urine toxicology in order to confirm the cause that it is a drug overdose. And there are some specific drugs which are relatively common that you can order for specific diagnosis in the serum that include acetaminophen, salicylate, TCA, and ethanol. So these are the specifics, and besides that you're going to order a blood and the urine toxicology. Next off, you're going to rule out some other cause. So if it's not a drug cause, is there something else that is causing these signs and symptoms? That include some acid-base disorder, rule out with ABGs, rule out rhabdomyolysis with creatinine kinase, carbon monoxide and methemoglobin, carbon monoxide levels and methemoglobin levels if the patient is hypoxic, unresponsive, and of course the oxygen saturation as well, and then the lactate levels in case it is some sort of an infection. So two main goals are you're going to establish the drug overdose with blood and urine toxicology along with specific tests of acetaminophen, salicylates, TCA, and ethanol, and then rule out other causes with ABGs, creatinine kinase, carbon monoxide, methemoglobin levels along with lactate. Next off, we have the treatment. So of course this is drug overdose, so we are going to do a wide sort of a treatment, and first of all will of course be the general supportive airway, breathing, and circulation. If the patient can't breathe, put him on intubate, mechanical ventilate, and prevent aspiration by putting in an NG tube with suction since it's possible that the patient has ingested something, and then in order to prevent further drug absorption after you have secured the airways, right? But if the patient is unconscious and you cannot protect the airway, we are not going to do this step. But if you have protected the airway, then you can, after NG tubes with suction, you can give him activated charcoal. So this was the general supportive measures, and this was also for circulation. You can also give IV access along with fluids if the patient is hypotensive, and even after the IV fluids, if the patient remains hypotensive, then you can give epinephrine, right? So this was the general supportive measures. Now after the general supportive measures comes the specific treatments. If it's opioid overdose, you can specifically give naloxone. If it's TCO overdose, give him soda bicarb. And if you suspect that the patient had actually done some sort of suicide, take the suicide precautions, removing the gun at the home, consulting social services, creating a safety plan, doing a suicide contract, and things like that, right? So for benzodiazepine overdose, again, you don't know if it's specifically benzodiazepine overdose. So you have to, again, do the confirm the cause for the drug overdose, and then rule out other causes just like we did previously. And the specific treatment, of course, the general supportive measures are the same, but one important thing is that you have to avoid activated charcoal. Why? Because it increases the risk of aspiration in benzodiazepine overdose. And of course the general supportive measures of fluids and psych consults still exist. Okay, then we have heroin injection. So specifically for heroin injection, since the people are injecting this heroin into their veins, so they are going to introduce some infection inside their body, so they might present with fever and sepsis. So the general fever workup or the infectious screen of course exists with all the cultures and the chest x-ray, but specifically since the patient is injecting by the help of needles, so it's possible that he has some sort of other STDs, which include Hep B, C, or HIV, which he got from the needles. So they need to be done. And of course, the people who are who use these injectable drugs are at an increased risk of infectious endocarditis, so get an echo done. So because it's fever and sepsis, number one, the infectious screen. Number two, rule out STDs with HIV and hepatitis panel. And number two, do an echo to rule out infectious endocarditis. And of course, in the treatment, go according to the cause. If it's Hep B, C, HIV, treat accordingly. accordingly. If you find some sort of infection from the infectious tree, treat accordingly, give the antibiotics, and if it's echo, of course, go accordingly. If on echo you find infections according to carditis, go accordingly. But one specific treatment is that if it's like specific, you have to consult infectious disease, and for the further management, you're going to consult substance abuse and social services if the patient is homeless and have some social issues. Next off, we have lead poisoning. So for the diagnosis, you're going to, of course, first of all confirm the diagnosis that it is lead poisoning by doing the lead levels. And if you suspect that the patient has specifically ingested paint chips, then you can do an x-ray of the abdomen. And if the patient has like signs and symptoms of head encephalopathy, then in this situation you can do a CT of the head as well, because lead intoxication has an increased risk of increased intracranial pressure, so get a head CT done as well. So confirming the diagnosis, three things: one would be the blood, and two would be the radiological, the lead levels, along with the x-ray and the CT of the head. Then you're going to establish associated infections. So it's classically known that lead poisoning causes microcytic anemia, so you are going to do a CBC with iron binding capacity. Next off, we have the treatment. So that would be the general supportive treatment with the fluids if the patient is hypotensive, and a lorazepam if the patient is actively seizing, and iron tablets as well if the patient has microcytic anemia. And specific treatment would be the antidote for lead poisoning, that includes EDTA and dimercaprol. And in the preventive treatment, we can do have a social worker who can visit the home for lead poisoning. This concludes our CCS cases rapid review for psychiatry and neurology. If you like this video, please like, share, subscribe, and follow for more. And I'll see you in the next video. Happy studying!